Well, good morning to everyone. Hope everybody was able to enjoy, at least to some extent, the three-day Memorial Day weekend. And thank you to those of you who were working, and particularly thank you to those who have served. Welcome back to today's Medical Grand Rounds. I am here live in Southern Auditorium at Providence St. Vincent. But of course, welcome to all of you who are out there on our virtual viewership on Teams Live. Grand Rounds is now a collaboration between St. Vincent and Providence Portland. We are always available virtually, but please come join us in person as you are able. That is always included in the weekly invitation to Grand Rounds, whether we are here in person or only virtual. And of course, you can also earn CME credit by being here in person, by watching live virtual, or by watching a recording of the session. And that recording is also the same link as the invite to Grand Rounds. I will hold questions and comments for the end to ask our speaker as time permits, but please go ahead and put those into the Q&A for our speaker today. And now to introduce Dr. Alexei Zemsky, who is a practicing electrophysiology cardiologist with Providence Heart Clinic Gateway. Dr. Zemsky earned his medical degree from Tulane University in New Orleans and went on to do internal medicine residency at the University of Chicago. Dr. Zemsky completed 2 fellowships at Harbor-UCLA Division of Cardiology, as well as a fellowship at Kaiser in the Division of Electrophysiology. Dr. Zemsky has earned several awards and honors, including a Resident Teaching Award and Chief Fellowship of Cardiology by the Harbor-UCLA faculty. We are so grateful for him to bring his excellence in both clinical care and teaching. Thank you, Dr. Zemsky, for joining us today.
Hello, everyone. Thank you for attending. It's really an honor to be here, and let's get started. So the title of my talk today is Atrial Fibrillation Management, a Bird's Eye Review. So I'm going to start off with a Shakespeare quote, as one does. So, a jack of all trades is a master of none, but oftentimes better than a master of one, which is to say that when you do one of these talks, there's really kind of 2 ways you can go about it. One is to do the inch wide and a mile deep approach, where you really dive into a very small subject and get into the nooks and crannies and go over every last detail of that subject with a fine-tooth comb. And that's probably the best way of doing one of these talks. But I, of course, chose the other way, which is to go mile wide and inch deep and really kind of look at this subject from a more holistic point of view and kind of look at the state of the art and how we manage atrial fibrillation for our patients at this point. So I hope it's of interest to you. So whenever a patient comes to one of our clinics or inpatient service with atrial fibrillation, and we start talking about atrial fibrillation management, there's really always been kind of 3 general areas that we always want to focus on. And this has been the case certainly from before I started practicing or training. And I think this will be the case as far as we can see into the future. And so those 3 things that we always want to talk about with our patients and address before the patient leaves our care are most importantly stroke prevention. So that's the one way that atrial fibrillation can really negatively impact a life is via stroke. And we know there's significant stroke risk conferred by atrial fibrillation. So it's on us to make sure the patient's appropriately treated for stroke prevention. The second issue is rate control. So we control our patient's ventricular rate during atrial fibrillation for any number of reasons, which we'll get into, but those are important as well. And then the final is really symptom management. And that's where I spend the majority of my time with atrial fibrillation patients. So usually by the time they come and see me, the stroke prevention piece or the rate control piece has already been addressed by the emergency room doctor or the primary care physician or whoever originally made the diagnosis. And I can really focus on whether or not the patient has symptoms and how we can help them with those symptoms. So the first question when we have a patient with atrial fibrillation is this patient at risk for stroke? And this question was kind of originally looked at in the initial randomized controlled trials of anticoagulation now over 40 years ago. And what we found from those studies is that atrial fibrillation is indeed associated with an increased risk of thromboembolic events, the hazard ratio being about 1.38. So a significant increase in the risk for stroke and other thromboembolic events with just the simple diagnosis of atrial fibrillation. But what we found in looking at those cohorts of patients was that risk was primarily based on demographic factors or disease states. And this wasn't for lack of trying to look for more objective or quantitative methods such as biomarkers, imaging criteria such as left atrial enlargement, other disease states such as renal disease, sleep apnea. But it was generally found that those more specific findings overlapped with the more general findings and didn't add a whole lot to our risk calculation. So we're left with a relatively simple risk calculation for whether or not our patient is at risk for stroke and needs to be treated. And then, of course, the CHA2DS2-VASc risk factors. So I think many of us use this in our daily practice, but just for a quick review, the CHA2DS2-VASc risk score refers to several demographic factors. So within the scoring method, you get 1 point for congestive heart failure, 1 point for hypertension, 1 point for diabetes, 1 point for vascular disease, being either coronary artery disease or peripheral vascular disease, 1 point for age 65 to 74, and 1 point with an asterisk for female gender. We also get 2 points for age greater than 75 years, and 2 points for a history of stroke, TIA, or systemic embolism. So we simply add up these risk factors and we get a CHA2DS2-VASc risk score. But just to go back here, just to touch on the gender issue, it's important to mention that female gender is not actually a risk factor, it's a risk modifier. And the reason for that is that if we have a woman with a CHA2DS2-VASc risk score of 1, that's in terms of stroke risk, that's equivalent to a man with a CHA2DS2-VASc risk score of 0. If, on the other hand, we have a woman with 1 additional risk factor, so a CHA2DS2-VASc score of 2, that's equivalent to a male with a CHA2DS2-VASc risk score of 2. So we don't treat all women with CHA2DS2-VASc scores of 1, but we do generally tend to recommend treatment for all women with CHA2DS2-VASc scores of 2. So how much additional risk do we confer on our patients based on this risk score? So this is looking at an adjusted annual stroke rate. So this is not the annual stroke rate, this is the additional stroke rate conferred by the atrial fibrillation risk in these specific groups of patients. So for a CHA2DS2-VASc score of 0 or 1 in women, there's really no additional stroke risk. So this is the lone atrial fibrillation cohort that we've known about for a long time, where atrial fibrillation doesn't actually increase the risk of stroke, and we can treat them for stroke as if they didn't have atrial fibrillation. For a CHA2DS2-VASc score of 1, we have a 1 to 2% increase in annual stroke rate. For a CHA2DS2-VASc score of 2, we have a 2 to 3%, 3 to 4%, 4 to 4%. And generally, as we add more risk factors, as expected, the risk of stroke goes up. And so the recommendation for anticoagulation becomes more and more emphatic the bigger the risk score. Generally, for patients with risk scores of less than 4, we don't recommend bridging around procedures, and for patients with risk factors 4 and over, we generally do. Also, patients who have a history of stroke, we tend to be a little bit more detail-oriented when it comes to bridging for those patients. But this raises an interesting question. So if female gender is associated with a longer lifespan, then why is female gender a stroke risk modifier? And I actually did a very extensive literature search for this. I used PubMed, I used Google Scholar, I used ChatGPT, Bard, everything, and I just couldn't find a good answer for that. But I was perusing the net last night. I think I may have stumbled upon the reason for this. So I just want to play this video for you. This is a German gentleman. Yeah. He's wearing swimming trunks. Looks like it's kind of cold where he is. He's posturing. He's getting excited about something. He jumps into a frozen pool. So we're going to get this in slow motion, which I think is very important for this discussion. The purpose of that video is just to say that when we're talking about gender-associated mortality, I think we have to consider other factors than simple CHA2DS2-VASc risk scores if we're going to do that. So, there we go. See what's going on here. I hope I'm not stuck on this for the remainder of the talk. Oh, thank you so much. Okay, perfect. All right, so which brings up another question, which is how does atrial fibrillation increase embolic risk? And so whenever we think about embolic risk, we generally are taken back to our time in med school and we learned about Virchow's triad, which states simply that hypercoagulability or coagulability is really dictated by three factors and how they interact. One being endothelial injury, another being a hypercoagulable state such as cancer or inherited hypercoagulable state. And then finally, stasis, which is really what we focus on in our mental model when we think about atrial fibrillation. I know that when I have an atrial fibrillation patient in clinic, we often talk about the way an atrial fibrillation heart looks in open heart surgery when you open it, and there's just no organized movement. There's just a wiggling of the atria. And we can naturally kind of imagine that velocity of flow through the atria is slower there. We can layer that on top of other things we've seen, like transesophageal echoes during atrial fibrillation, where there's spontaneous contrast or smoke in the atrium, and you could actually see the stasis. And it creates this mental model where atrial fibrillation leads to stasis, stasis leads to clots, clots lead to dislodgement of clots and embolism, and that leads to strokes. So is that actually the case? Is that how atrial fibrillation causes embolism? So this is a study that looked at device-detected atrial fibrillation and the risk of stroke in a large cohort of patients. So this was a pooled analysis of over 10,000 patients from 3 previous prospective observational studies. All the patients had an implantable device capable of detecting atrial fibrillation or atrial tachycardia. So in general, these are dual chamber devices with an atrial lead that can reproducibly and reliably catch all episodes of atrial fibrillation. All the patients included had at least 3 months or greater follow-up, and the exclusion criteria for entry into the study were patients who were already diagnosed with permanent atrial fibrillation. So what were the findings in this study? So we're looking at a hazard ratio bar chart where anything above the line represents an increased risk for stroke, and anything below the line would represent a decreased risk for stroke in this cohort of patients. And so on the left side of this graph, we have kind of all of the CHADS-VASc risk score parameters. So age, greater age, diabetes, prior stroke, CHADS score, female gender, anticoagulants, antiplatelets, and a combination of anticoagulants or antiplatelets. So patients who are already anticoagulated or already on antiplatelet drugs. And we see that all of those factors confer more risk, with maybe the exception of female gender, which crosses that identity line and so is not significantly increased. And that probably is why this is a risk modifier, not a risk factor, gender. But what I want to focus on in this slide is the right half of the slide, where we look at risk of embolic event based on duration of atrial fibrillation. So this is simply going from greater than or less than 5 minutes of atrial fibrillation detected by device, greater than or less than 1 hour of atrial fibrillation detected on device, 6 hours, 12 hours, or 24 hours. And what we see is that as we have more atrial fibrillation detected on device, the risk reproducibly goes up. So being more than a day confers more risk than being more than 12 hours. Being more than 12 hours confers more risk than being more than 6 hours. Being more than 6 hours confers more risk than more than 1 hour. And having more than 1 hour confers more risk than more than 5 minutes. And having more than 5 minutes confers more risk than having none at all. So I would view this study as being very supportive of the stasis theory for the mechanism for stroke in atrial fibrillation. But that's not the only study. So I want to present a different study with somewhat of a different message. So this was a study looking at the temporal relationship between subclinical atrial fibrillation. So these are patients who have atrial fibrillation detected on devices, but don't necessarily have symptoms of atrial fibrillation or a prior diagnosis of atrial fibrillation, who go on to develop embolic events. So this was about 2,600 patients, all of which had age greater than 65 and with hypertension, who had received a newly placed dual chamber device, either a pacemaker or an ICD. The exclusion criteria for this study was either prior clinical atrial fibrillation or already being on anticoagulation. And so what happened was all the device data was recorded and sent to the investigators, and then the device data was adjudicated for the presence or absence, the time of initiation, and the duration of atrial fibrillation episodes. And then if the patients went on to have embolic events after the first 3 months of the study, they were included in the subsequent analysis. So again, the idea is we're looking for an association between atrial fibrillation events and subsequent embolic events. So the findings for this study were that 51 of the patients went on to have a stroke or an embolic event. And interestingly, only about half of those patients had any atrial fibrillation before or after the embolic event. And this is, I think, somewhat intuitive. We know that atrial fibrillation is not the only way that someone can have an embolic event. There's also carotid disease and any other number of factors, endocarditis. There's a lot of reasons why you can have an embolic event. But about half of them were in some way related to the diagnosis of atrial fibrillation made by device. But if you take that 51%, only 35%, so about 1 in 3 of those patients had any atrial fibrillation at all detected before the embolic event. So they've all been followed for greater than 3 months, and only a third of them had any atrial fibrillation prior to the event. And then finally, only 8%, so less than 1 in 10 of these patients who went on to have stroke had greater than 6 minutes of atrial fibrillation in the 30 days prior to event. So it's hard to imagine a patient having, a day of atrial fibrillation 3 months prior to event and then going on and having a stroke 3 months later. In general, that's a little bit unintuitive. So I think that very much presents the other side of the coin, which is that there's not always a clear relationship between the mechanistic movement of the atrium and subsequent stroke. So it's a complex message. And so when I think about it, I think of atrial fibrillation as being a marker for stroke risk, not necessarily mechanistically, but it could be a marker for endothelial inflammation, could be a marker for poor movement of the atria, it could be a marker for an atrial cardiomyopathy. But in any case, I know that once that patient has that diagnosis of atrial fibrillation, they are at increased risk. And this is important because these questions come up very often in clinic where a patient will say, look, I've got a pacemaker, I haven't had any atrial fibrillation for 6 months, why am I still on my NOAC? And so it's important to remember that there's not always that clear relationship and that the burden of proof is really more in support of continuing anticoagulation despite not having direct evidence of whether they're having symptoms or device-detected atrial fibrillation. So now that we know that atrial fibrillation confers the risk of stroke in some manner, how do we treat stroke risk for atrial fibrillation patients? So the original agent used, of course, was warfarin or Coumadin, or vitamin K antagonists. And this was shown to decrease stroke risk by 64% and overall mortality by 24% compared to placebo in atrial fibrillation patients. The vitamin K antagonists remain the only proven options for patients who have valvular atrial fibrillation. So these are patients with generally mitral valvular disease, mitral stenosis, rheumatic heart disease, or patients who have had a mechanical valve replacement. But in the last 20 years, we've of course had NOACs, thank God, and they've been compared to the vitamin K antagonists in a large meta-analysis. And in general, the findings were very positive for NOAC. So a patient on a NOAC versus warfarin had a 19% decrease in stroke or embolic risk, a 51% reduction in hemorrhagic stroke, an equivalent reduction in ischemic stroke, and a 10% decrease in all-cause mortality relative to the vitamin K antagonists. Of course, there's no free lunch in medicine, so there is an increase, a 25% increase in GI bleeding in our NOAC cohort. For this reason, I think that NOACs are now the first line therapy unless there's a reason the patient can't take it, such as valvular heart disease, mechanical valve, not being able to afford it, allergy, etc. So in general, the first pull is always a NOAC. Which one you take is I think up to you. So what are our options for patients who do have bleeding contraindications? What about the patient who has a history of hemorrhagic stroke who comes to us with a new diagnosis of atrial fibrillation? And in general, there are two main options at our disposal at this point. There's either surgical left atrial exclusion, so that's oversewing of the left atrial appendage. As we all know, the majority of strokes, although not all strokes in atrial fibrillation, tend to originate in the left atrial appendage, where thrombus tends to occur. And so surgical oversewing of that appendage can greatly diminish the risk of stroke. And this has been known for many years and has been a part of our surgical treatment for atrial fibrillation patients who are undergoing surgery for other reasons. But more recently, we've had left atrial appendage occlusion devices, the FDA approved one being the Watchman device, which is placed via transeptal puncture, generally from the groin. And it's just a little basket, which you can see here, which is placed within the opening of the left atrial appendage. Over time, the device gets endothelialized and the appendage becomes entirely excluded from the systemic circulation. And that's used for stroke prevention in high-risk patients who also have a contraindication to being on ongoing anticoagulation. So what does our data about Watchman tell us about the efficacy of the Watchman device versus warfarin? So this is a look at a compilation of two studies, the PREVAIL and the PROTECT AF trials, that looked at left atrial appendage closure with Watchman device versus warfarin. So again, we have a hazard ratio chart here, looking at outcomes that favor Watchman placement versus outcomes that favor ongoing warfarin. So again, this is warfarin, not the novel anticoagulants, and this is comparing warfarin to Watchman. So what we see is that they're essentially equivalent with a couple of exceptions, one of them being, and this is the most important, hemorrhagic stroke is less of a risk in the Watchman cohort, as expected, since they're no longer anticoagulation going forward. In addition, unexplained death is decreased for some reason in the Watchman cohort. And also intuitively, major bleeding that's not procedure related is decreased in the Watchman cohort. So looking at this, one might think, well, why aren't we using Watchman in all of our patients? But that's not in fact what we do. So when we talk about Watchman placement, there's several disclaimers. And the first is that the procedure itself has significant bleeding risks, including tamponade or the need for open heart surgery. That's about a 1 to 5% procedural risk. So that's a real risk. When we look at the registry data that's been released after the original studies, we see that in the real world, there are higher rates of procedural complications than in the large centers that were used for the original studies. So we're probably underreporting or underestimating the procedural risk in these patients, which would be reflected in the outcomes data from those trials. In addition, there have been several studies that have reported a significant number of device-related thromboses in patients who cannot take anticoagulation in the initial months following Watchman placement. So in general, these patients are on anticoagulation for at least a month after Watchman placement for that time period prior to endothelialization. And in that group of patients, there's been a good description of thromboses that can occur in up to 10% of patients, and these confer an increased risk of stroke when they have the thrombosis on the Watchman device. And so for all of these reasons, we don't put these in for patients unless they have an absolute contraindication to oral anticoagulation. So we're using this as a bailout for patients who are at significant risk of stroke who can't be on either NOACs or on vitamin K antagonists. So now that we've discussed the stroke risk in our atrial fibrillation cohort, what do we do next as clinicians when a patient presents to us in atrial fibrillation? So the next thing we do is we focus on the ventricular rate for our atrial fibrillation patients. So in this group of patients, it's long been known that at the very minimum, you want to control the stroke risk and control the ventricular rate. And the reasons for that are really twofold. One is that a significant number of patients will have symptoms in rapid atrial fibrillation and no symptoms in rate-controlled atrial fibrillation. So we can mitigate symptoms simply by controlling the rate with AV nodal blockade. And more importantly, we know that a small cohort of these patients will develop a tachycardia-mediated cardiomyopathy. So we see this not infrequently where a patient will have a prior history of a normal EF. They'll come in rapid atrial fibrillation and their EF will be 35 or 40% in atrial fibrillation. Will in some way slow down their heart or convert them to a normal sinus rhythm, and we'll see that ejection fraction rebound. So there's this clear temporal relationship of tachycardia with cardiomyopathy. So very important that we avoid the cardiomyopathy in that group of patients. So for all patients, we're recommending rate control. What agents do we use for rate control? Well, this would probably be the same same slide I would show you in 1989 if I were giving this presentation in 1989. There's not a whole lot new under the sun when it comes to rate control. But in general, the first line therapy tends to be beta blockers. You can choose the beta blocker of your choice. In general, selective beta blockers are preferred over non-selective, just so we have more blood pressure to work with, unless the patient's very hypertensive. Contraindications for a beta blocker would be severe asthma and bronchospasm induced by beta blockers, or acute heart failure. So obviously we don't give beta blockers when patients are in cardiogenic shock, which we can see sometimes in rapid atrial fibrillation patients with heart failure. So that's beta blockers. The second line agent tends to be non-dihydropyridine calcium channel antagonists. So these are verapamil or diltiazem that have a strong rate control effect. The thing we run into with these agents is that we can't use them in patients with diminished EF. So EF less than 50, in general, we're not using these patients unless we really have no other options. And we have to adjust our doses in the case of hepatic or renal impairment. Then there's the digitalis glycoside. So these have been around for a very long time. They've gone in and out of favor over time. But we know that patients who have high plasma levels of the digitalis glycosides are at risk for increased mortality. So very important that we're very careful in dosing these patients, particularly if they have renal dysfunction. And we have to adapt our dose in chronic kidney disease patients. Finally, sometimes, particularly as an inpatient, we run into the case where we're unable to get the heart rate under control with the above agents, and we have to use a different agent, which is amiodarone, which is has beta blocker activity in addition to true antiarrhythmic activity. So the contraindications for amiodarone, first and foremost, when we're giving amiodarone, we're of course raising the possibility of causing a pharmacologic cardioversion, which can paradoxically increase the risk for stroke going forward. So in these patients, if we're feeling that we have to give amiodarone to control rate, we really want to make sure we've covered the stroke risk. So they have to have been on anticoagulation for a month or so, or have had a negative TE prior to starting it, unless they're hemodynamically unstable, in which case you've got to do what you've got to do. In addition, amiodarone, as we know, for chronic use has a long list of toxicities which have to be monitored for. Those include pulmonary toxicities, liver toxicities, skin, eye, thyroid. And it's contraindicated for patients with hyperthyroid disease. So in patients with elevated thyroid, you just absolutely cannot use amiodarone because of the iodine load. But is digoxin safe? So I think there's a lot of caution when it comes to digoxin use, and that's because several observational studies have associated digoxin use with increased patient mortality. And so we're understandably a little gun shy about using digoxin. But when we think about digoxin, we have to think about the type of patients that we're using them in. We're not using digoxin in patients who are 35 years old who come in with holiday heart. We're using them in general in patients who are hypotensive, and that's why we're pulling digoxin as opposed to a calcium channel blocker or a beta blocker. We're using them in patients who tend to be much sicker. So it could be the heart failure, maybe a patient with acute heart failure, or a patient with chronic heart failure where we can't use the calcium channel blocker. We're pulling the digoxin. So just using digoxin is really a marker for a sicker patient population. And in fact, when we look at randomized control trials of digitalis and heart failure patients, what they found was that there was a neutral effect regarding mortality. So it didn't improve or reduce mortality, but there was a significant reduction in hospitalization. So we have to be careful with digitalis. We have to remember that we're using this in a sicker patient population, but in general, we don't believe that digitalis is causing increased mortality effect if administered properly for our patients. So we know what agents we're going to use. We know that digoxin can be used if we need to, but what's our goal for rate control? And so this has really kind of varied over the years. And so looking at different trials, we're able to kind of answer this question in a data-based manner or an evidence-based manner. So this study looked at whether the intensity of rate control influences outcome in atrial fibrillation. And it was basically using two separate studies, the RACE study and the AFFIRM studies, which we'll discuss later, to look at outcomes in patients with atrial fibrillation. So this was a trial of stringent versus lenient rate control using these two different studies. And stringent was based on the AFFIRM study, which had a goal resting heart rate of less than 80. And lenient was the RACE study, which had a goal resting heart rate of less than 110. So two rate control studies with different goals. And the idea is to look at the primary endpoints of composite mortality, cardiovascular hospitalization, or MI. The secondary endpoints included those individual endpoints that went into the composite, as well as the need for a pacemaker implant. And these were the findings. So when we look at event-free survival, there's a trend towards an improved outcome in the RACE study, which again is the lenient study. That's the dotted line here. So we see that there's less events going forward, but it's not a significant finding. The p-value is 0.099. The only significant finding was that pacemaker-free survival was significantly less, as expected, in the lenient study versus the more stringent study, the AFFIRM study. So as time goes on, more pacemakers in the AFFIRM group, and this is a significant finding. So what does this mean about our goals for rate controlling our patients? So this flow chart just says there's a whole lot of reasons why you want to control the rate in your patients. So all patients with atrial fibrillation have their rate controlled for reasons we've already discussed. Patients with minor symptoms, rate control can be enough. We can control the rate, prevent stroke risk, and then do not pass go. Rate control is necessary for patients who we try to rhythm control and determine that we're unable to rhythm control them, whether it be through medications, antiarrhythmics, or invasive procedures. And finally, when we determine that this is a patient we would like to do rhythm controlling, but the risk of rhythm control outweigh the benefits in that patient. So I would think of a patient who we do a TE, we see a left atrial appendage thrombus, we don't want to get them back into sinus rhythm. That's a good reason to focus on rate control while you wait for that thrombus to resolve. So because of the results of the previous study, in general, our first line is lenient rate control. And this means that we're shooting for a resting heart rate of less than 110. And this comes up, I find, a lot in the inpatient population. So we get a lot of consults for patients because they're having uncontrolled tachycardia. And we'll look at the telemetry monitor and we'll look at the average heart rate over time. And the average heart rate will be fine, but there'll be scores of alarms for heart rate 140, heart rate 150. So we really want to focus on an average heart rate, the resting heart rate. We want that heart rate less than 110. And if we're there in general, unless there's something else going on, that's sufficient. That patient is kind of out of the risk window. But there are groups of patients where that's not the case. And so in general, these are patients who are in atrial fibrillation, who have an impaired EF, so an EF of less than 50, or patients who already have a biventricular device. And so when we have uncontrolled atrial fibrillation in a BiV patient, they're not getting the benefit of BiV pacing. So we'll look at their BiV pacing percentage. It'll be less than 90%, and they're not getting the benefit of that device to treat their underlying heart failure. So for those patients, so again, evidence of heart failure or prior CRTP or CRTD, we're aiming for that lower AFFIRM type heart rate. So we're looking for a resting heart rate of less than 80. So again, for patients with CRT, we're doing this because we want to maximize biventricular pacing so they get the benefits of biventricular pacing, which is the reason they got the device in the first place. If you want to be very stringent about it, and to be honest, we don't always do this, but you can assess heart rate during exercise to make sure that you're meeting their exercise heart rate goals as well. In general, that's exercise heart rate of less than 110 beats per minute at 25% of their maximal exercise time. So if they go 10 minutes on a Bruce protocol, you look at the first 2.5 minutes and make sure their heart rate's less than 110 beats per minute. And then oftentimes we'll perform 24-hour monitoring at minimum in these patients to make sure they're not having bradycardia events that we're not aware of at this more stringent rate control once we've initiated it. So one of the classic questions in atrial fibrillation management is, when do we use rate control versus when do we use rhythm control? So is it worthwhile to try to get patients in atrial fibrillation back into sinus rhythm? And prior to this study, which is the AFFIRM study, I think there were a lot of theories about why you would want to get all of your patients back into sinus rhythm. So tachycardia begets tachycardia. Decrease the risk for heart failure, decrease the risk for hospitalization, allow the patient to have improved hemodynamics with atrioventricular synchrony. And this study really kind of changed the way we manage atrial fibrillation. This is from a long time ago, over 20 years ago, and it's the AFFIRM study. So the AFFIRM trial looked at over 4,000 patients who were all 64 years of old or greater and had other stroke risk factors. So think of these as men with CHA2DS2-VASc score of 1 or greater and women with a CHA2DS2-VASc score of 2 or greater. It was a randomized controlled trial, and patients were randomized to either a rate control strategy or a rhythm control strategy. For the rate control arm, the goal, as previously mentioned, was a resting heart rate of less than 80, and this was achieved with a combination of beta blockers, calcium channel blockers, and digoxin. For the rhythm control strategy, clinicians were allowed to choose their antiarrhythmic, and this really included all antiarrhythmics that we have at our disposal. So it was totally up to the clinicians. And then if they didn't spontaneously convert with antiarrhythmics, they went on to get cardioversion. For this group of rhythm control, they had to fail at least 2 agents before they were allowed to move on to invasive approaches. And those approaches would be things like catheter ablation or pace and ablate strategies, where we put in a pacemaker and ablate the AV node. The mean follow-up time was 3.5 years, and about 5% of patients went on to undergo invasive procedure, whether it be AFib ablation or AV node ablation. So what were the results of the AFFIRM trial? So again, we've got a hazard ratio chart here, and I'm pointing out which groups of patients had a significant difference in hazard ratio. And so we see in patients greater than 65 years of age, there was a trend towards rate control being better for the primary endpoint. Same was true of patients with coronary artery disease and patients who didn't have heart failure. There was a trend towards patients with heart failure doing better with the rhythm control, but not a significant trend. So those were the only significant findings in the subgroup analysis. There was also a trend towards more deaths in the rhythm control group, probably attributable to the toxicity of antiarrhythmics in and of themselves. So there's clearly pro-arrhythmic effects in all antiarrhythmics, and particularly with the amiodarone, there are a lot of other side effects that can increase our risk of death. But overall, the composite endpoint was similar in both groups, and they both had similar stroke rates. All of these patients were anticoagulated. So is rate control truly equivalent to pharmacologic rhythm control as suggested by the AFFIRM study? So the answer to that is Wysiati. So Wysiati is a term that was coined by Daniel Kahneman, the Nobel Prize-winning behavioral economist, and it hints at a cognitive bias that we all have. It's what you see is all there is. So what was not present in the AFFIRM trial? What was not in the endpoint? What are we missing? What are we not seeing that would affect the answer to that question? So what aren't we seeing? Well, number one is symptoms. So again, the reason why we put patients on antiarrhythmics or do ablations is to mitigate their symptoms. It's not to prevent heart failure, it's not to prevent stroke, it's just to improve their symptoms. So if we don't look at symptoms, we're not going to see the benefit of treating symptoms. The heart failure cohort, so this wasn't powered to look at patients with heart failure. So there's a possibility that heart failure patients could derive more benefit from rhythm control than non-heart failure patients, and that was maybe suggested in the hazard ratios I showed you. And then there was no catheter ablation. So obviously that's a large part of what we do within electrophysiology now is we treat our patients who fail medical therapy with catheter ablation. So there's a possibility that catheter ablation would give us a different result for rhythm control versus the pharmacologic approach. So that brings us to atrial fibrillation and heart failure. So as we know, the prevalence of atrial fibrillation increases with severity of heart failure. So the more heart failure you have, the more likely you are to have atrial fibrillation. And so we look at it by New York Heart Association class of heart failure. For class 1 patients, there's about a 5% prevalence of atrial fibrillation, but for class 4 patients, there's about a 50% prevalence, and it moves up in a stepwise manner. We also know that atrial fibrillation in patients with CHF leads to worsened hemodynamics. We can see this with Swan-Ganz data and worsened symptoms. So heart failure patients are particularly brittle. They go into atrial fibrillation, they're likely to have a heart failure exacerbation. And finally, a firm type rhythm control, or a rate control in the CHF cohort has not been shown to improve outcomes in the randomized controlled trials. So is there a role for catheter ablation in this CHF cohort? This is a New England Journal article from 2018. This is the Castle AF study. So this is a randomized controlled trial of 363 patients with New York Heart Association 2, 3, or 4 heart failure and ejection fractions of 35% or less. The patients all had defibrillators. The exclusion criteria for these patients was transplant candidacy or a planned cardiovascular intervention. So this would be something like an ablation or an AV node ablation or a pacemaker replacement. The patients within the study were randomized to 2 strategies. One was either pulmonary vein isolation via catheter ablation, whether that be cryoablation or radiofrequency ablation, or medical therapy. And the medical therapy included both rate and rhythm control, but it was mostly rhythm control, pharmacologic rhythm control. And the patients had home monitoring of their ICDs for AF surveillance. So we were able to reproducibly see whether or not they were having atrial fibrillation. And this was really the first study that looked at a really hard endpoint, which was death hospitalization for CHF, composite endpoint. So what was the finding of the Castle AF study? So this first graph looks at the death or hospitalization rate for worsening heart failure, so the composite endpoint over months of follow-up. And we see that the ablation group had a tendency towards improved event-free survival, and that it was significant. The p-value is somewhere between 0.06 and 0.07, and the hazard ratio spans 0.43 to 0.87 for patients undergoing catheter ablation. So we're seeing a significant reduction in the primary endpoint in the ablation cohort. Similarly, when we look at mortality, we also see that although in the beginning of the curve, presumably in the first 6 months after ablation, when complications are likely to occur, there might have been equivalents or maybe even more events in the ablation group. As time goes on, the ablation group tended to do better. Again, with a significant p-value, improved mortality in heart failure patients who underwent ablation versus medical therapy. So at least in this heart failure cohort, sometimes we'll be much more aggressive than we would be otherwise in a patient. So we're going to try our hardest to get the patient back into sinus rhythm to confer this benefit of decreased hospitalization and improved mortality in our heart failure cohort. We also see hospitalization for worsening heart failure, a significant finding of decreased hospitalizations for heart failure in the ablation group. So does catheter ablation effectively treat atrial fibrillation symptoms? So there's another question for you. And this was the one really large randomized controlled trial we have. This was the Cabana trial. So the Cabana trial was a randomized controlled trial of over 2,200 patients between 2009 and 2016. And the patients were randomized to either catheter ablation with either radiofrequency or cryoablation versus medical therapy. And this included rhythm and or rate control. And again, this had a hard primary endpoint of death, stroke, bleeding, or arrest. But the secondary endpoint was quality of life measures. And we're not going to go into the primary endpoint, but I can just tell you it was a negative study. There was no significant difference between the ablation and the medical therapy group. So we're not performing ablations to avoid death, stroke, bleeding, or arrest. Again, we're performing them because we want to improve our symptoms in our patients. So the secondary endpoint were these long-term quality of life measures. There are 2 different quality of life surveys that were used within the study, and that's what we're looking at in this study. So when we look at the patient response for atrial fibrillation within the last months at 1-year follow-up, we see that in the catheter ablation, there was across all time periods other than baseline, there's a decreased incident of reported atrial fibrillation in the prior month, as reported by patients. There's a trend towards at least patient perception of their atrial fibrillation being under better control. And similarly with both of the quality of lives, I'm showing you the Mayo atrial fibrillation symptom inventory quality of life score, but it was true also of the other quality of life score. There's strong evidence that a quality of life was improved in this cohort of patients with atrial fibrillation ablation versus drug therapy. The only time period where that wasn't the case was at baseline, as would be expected. So there's a significant improvement in quality of life based on patient reporting with ablation versus medical therapy. So there is some role for ablation, at least in patients who are having symptomatic atrial fibrillation. So what are some exciting future developments? What's coming down the pipe? What am I excited about as an electrophysiologist looking forward? What am I going to be able to offer my patients going forward that perhaps I can offer today or I can't offer today, but I don't know what the outcomes are going to be for these. So what are the exciting things coming down the road that I don't really have answers for you today? So I think what I'm most excited is about this new ablation technology that's under investigation right now. It's electroporation. And this is a different way of ablating. So classically, what we've used for ablation is either heat or cold. So radio frequency, which is similar to what we use when we're using a Bovie in the operating room. It just applies heat at the tip of a catheter and cauterizes the atrial endothelium. Or cryoablation, where we use a balloon and fill it up with very cold gas and kind of freeze the tissue and kill it via freezing. That's what we've been using to date, and those have both been effective. But the issue with both of those approaches is that they're very non-selective. So when we apply heat or cold, as long as any tissue gets up to a certain level of temperature, if with heat, or down to a certain level of temperature with cold, that tissue is going to die. So cold is cold, hot is hot. It doesn't matter if it's an atrial cell or an esophageal cell or a phrenic nerve cell. It's non-discriminate. So electroporation is a little different. It's an ablation technique that uses high voltage pulses to create holes in the cell membrane of cells. And most importantly, it's specific for cell types. So these different cells have different frequencies at which they're vulnerable. And so you can target the atrial tissue without targeting the adjacent tissue. So there's the hope, at least, that when we get a nice big lesion in the atrium, we're not getting nice big lesions elsewhere. And for any interventionalist of any type, what keeps you up at night, what keeps you from sleeping and eating is the fear and the actual events of complications. This is what we hate to see in our patients. So there's some hope that we can get similar results in terms of ablation success with decreased collateral damage, which is a very enticing option. And this is being studied in ongoing trials, including the pulsed AF and beat AF trials. And as soon as we have results for those, we'll let you know one way or the other. So that's exciting. So leadless atrial pacing. So we've had leadless pacemakers for a while, and we use them relatively frequently. They're actually pretty elegant for pace and ablate patients because you can place the leadless pacemaker and do the AV node ablation at the same time, as opposed to waiting for the pacemaker to mature and make sure there's no dislodgements or infections. We know that these leadless pacemakers have a decreased risk of infection. So they're attractive in patients who are at higher risk for infection, dialysis patients, patients with multiple leads, patients with history of MRSA or other endovascular infections. But what's really exciting is that there was recently a New England journal that showed the feasibility of a dual chamber system whereby a leadless pacer is implanted both on the septum of the right ventricle as well as in the appendage of the right atrium. And these two pacemakers can talk to each other, and so you get the benefit of dual chamber pacing without having a full leaded system and all the disadvantages of that. And so I think this raises a lot of interesting use cases for our atrial fibrillation patients, one of them being the tachybrady population. There's a lot of data in Europe for using single chamber atrial pacing for that group, because what they have is sinus node dysfunction, not AV nodal disease. We haven't traditionally done that in America, but I think with this, there'll be a compelling case to just place an atrial pacemaker alone, and then that allows you to be more stringent with your rate control to try antiarrhythmic agents that otherwise would cause symptomatic bradycardia. I think that's pretty nice. And then for our patients with tachybrady, patients who do have some AV nodal disease, we can get the benefits of leadless pacing, AV synchrony, without having the risks of leaded pacers. So that's coming down the road. We have a feasibility study that came out last week in the New England Journal. It showed that the dual chamber system is feasible. So we'll see how it behaves in the real world. And then finally, something that we're already doing quite a bit of is conduction system pacing. So this started off with his bundle pacing. In general, this is just a normal pacemaker. The only difference is where we place the ventricular lead. So classically, we've just indiscriminately placed the lead on the septum or the apex of the right ventricle. With conduction system pacing, we target specific areas. So it started out with his bundle pacing, which gives you a beautiful narrow QRS complex. It basically activates the His bundle as opposed to activating the myocardium, and you get physiologic activation of both the left and right bundle. So it's like resynchronization with just a single pacemaker lead. Unfortunately, with His bundle pacing, what we saw is oftentimes we'd place a His bundle pacer. It would have beautiful QRS, it would have a beautiful threshold, beautiful sensing, everything would look great. And then about 6 months later, there would start to be a fibrotic process where you start to have elevating thresholds. They didn't age well. So they looked very promising. So that brings the left bundle branch area pacing, where instead of targeting the His bundle, we target a little bit more apical and we target much deeper. So we actually screw the lead deep into the septum by turning the lead continually until it bores into the septum until we capture that left bundle area. And that has shown some promise in terms of aging in a much more predictable manner, more like a typical lead. And we do get very physiologic looking QRSs. So the use case for this would be patients who previously replaced BiV pacers and then did an AV node ablation. So patients with maybe a little bit of heart failure, maybe EF of 40, 45%, those patients will tend to just put in a BiV system and then do the AV node because we don't want to worsen their heart failure with ventricular pacing. There's hope that this form of pacing, which is quicker, easier, if it showed significant clinical benefit, we could do this on most patients. Will give us an option for those patients, which will be cost effective and good for the patient. So we don't have the data for that yet, but it's certainly something I'm excited about.
Great. Many thanks, Dr. Zemsky. I'll lead us off with a question here online and then take questions from the room. We often find patients with asymptomatic, quote, new AFib at our pre-op clinic visit. These are often time-sensitive operations, but not urgent. If they have a normal TSH and echo and are rate controlled, would moving forward with surgery be reasonable?
Yeah, that's a great question. So in general, the answer to that question is yes. There's no reason why a patient with rate controlled atrial fibrillation can't undergo surgery. We certainly have large cohorts of patients that we take care of who we perform rate control in, and we routinely send them for surgeries for other reasons. The things that we always look at in these patients are we missing anything? So if this is a patient with truly a de novo diagnosis of atrial fibrillation, and we don't have any information about their LV function, it would be prudent to get an echo at that time and make sure the patient doesn't have heart failure, because that certainly would increase their risk for cardiovascular events. Have we looked at their coronary artery disease? So basically, all the things we're looking for in a pre-op clinic visit, we have to make sure that we've been even more assiduous with those factors when it's an AFib patient, because they're kind of telling us that they have some increased risk just by virtue of them having atrial fibrillation in the first place. But assuming we've done the normal risk stratification, then we would do normal anticoagulation management in and around the time of surgery. So for low CHADS VAS scores, that'd be a simple holiday from anticoagulation. For high CHADS VAS scores, we talk about bridging. But yeah, I tend to agree that in that truly asymptomatic patient with rate controlled atrial fibrillation, there's no reason not to proceed to surgery.
Great. I'm going to ask a second question here, partially out of interest. Some of our own residents recently presented a very interesting case of an atrial esophageal fistula after ablation. And there is a specific question here whether PPIs are ever used as a preventive strategy.
They're routinely used as so every patient that gets an AFib ablation goes home with PPIs, and this is our most feared complication from AFib ablation. And they happen very, very rarely, but when they happen, it's just an awful outcome. And so we do everything we can to avoid these, but I think in our institution's history, we've had 3 of them now over the last 25 or 30 years, and they're just terrible outcomes because these patients generally present with strokes. So You get embolization from the esophagus into the atrium, and then endocarditis from the atrium and distal embolization to the brain. So it's a devastating finding. There's a number of strategies that have been looked at to avoid this. The problem is that it's such a rare outcome that it's almost impossible to do a statistically significant study to see whether any of these things work. They just occur so rarely. But those include things like movement of the esophagus. So routinely during the ablation, we place temperature probes and move them around to the area that we're ablating and make sure there's no temperature rises. If the temperature rises in the esophagus, we come off the ablation. So we do that in all of our cases. But sometimes there are devices that you could use to actually move the esophagus. So you can see if you're close proximity, you could laterally displace the esophagus so that it's no longer in the vicinity of your ablation. There are cooling systems that do flow of cold water through the esophagus that have been looked at. But again, the real challenge is that we don't have statistically significant findings for any of these interventions, so we don't know if they work or not.
Thanks so much for this. I have two questions. I'll start with what may be the simpler one. Somewhere along the line, I was taught that having DIG on board doesn't help rate control when you've got paroxysmal AFib, whereas having a beta blocker or a calcium blocker on board does. Is that just something somebody made up and got stuck in my brain?
No, I think there's some truth to that. So in general, the mechanism of action of digoxin or the digitalis glycosides is parasympathetic. So it's an augmentation of the parasympathetic tone. And so if you're in a hyperadrenergic state, it just drowns out any. So if you have a patient who's just popped into AFibs going 106, they're going to have really, really high levels of endogenous sympathetic hormones. And so in general, the digoxin doesn't work very well for those. So it tends to work better in kind of the elderly patient who's not very active, not exercising. So I don't know that it's paroxysmal versus persistent, but it's really that adrenergic versus parasympathetic state.
Great, thank you. And I'm having a little trouble still wrapping my head around that it may not be stasis that's the problem. And because I feel like, if stasis weren't the problem, then why is it clot in the left atrial appendage? And why would the Watchman work if it wasn't something about stasis? Do you have more thoughts on that?
Yeah, so again, I think it's stasis plus, so it's not simply stasis, because we have clear evidence of cases of stroke in the setting of atrial fibrillation where the vast majority of patients didn't have an attributable event that caused it. So it's not simply that. So it could be something as simple as the movement is always impaired because these patients have an atrial cardiomyopathy, or there's an inflammatory state that predisposes them to develop systemic side clots. So I don't have the answer for you, but I do know that just because a patient hasn't had atrial fibrillation in a attributable time frame doesn't mean they're not going to have a stroke. That's clear from the data. But it's not intuitive. I think all of us have a mental model that's probably more simplified than the real world model.
It seems like with the smartwatches, there are some people saying, since you can really know that you haven't been in AFib for a year, then maybe you could come off anticoagulation, but you would not recommend that.
Yeah, I mean, as with anything, it's a conversation with the patient, but certainly, a smartwatch is not as good as an atrial lead in terms of sensitivity for atrial fibrillation. And we know that in that cohort of patients, even the absence of subclinical AF did not necessarily protect them from stroke events. So, and we know that anticoagulation works. So in general, and I think that as an electrophysiologist, I'm very biased in this because what I see are the patients who have a CHA2DS2-VASc of 1 and then come back with a stroke, and that's devastating. And so, I'm dealing with a lot of these patients, so I'm seeing the outliers. But anecdotally, I've regretted not starting anticoagulation a lot more than I've ever regretted starting it.
I know we're 1 minute to the hour, and forgive me as I've simplified my thinking. I guess I'll say true or false. If you're under 65, but your smartwatch found AFib, it would be best to stay in rhythm control since AFib begets AFib, right? I mean, that is the shift that we're doing for younger people. And would I send those people to you? Or would I try myself with some drug to keep them out of AFib?
Yeah, that's a great question. So I think if we went strictly by the data, a truly asymptomatic patient, you can make a strong argument for just rate controlling them and if they're truly asymptomatic. As EPs, we tend to not take patients at their word, and so we'll usually give that patient a trial of sinus rhythm. So they come in atrial fibrillation and they say I'm asymptomatic. We're going to make them prove it by cardioverting them and really making sure that they're, because sometimes people kind of slowly adjust their activity levels, and you cardiovert them, they say, well, you know, I actually feel much better in sinus rhythm than I did in atrial fibrillation. So we're going to make them prove it and at least do a drug trial on those patients. But we're happy to see those patients. Those are kind of patients we see every day and love taking care of. But I do think, even if you look at the data, the trend was towards rate control being better in older patients, and there was a trend towards younger patients doing better with rhythm control. And I think that's you know, it's a trend. It's not a significant finding, but it is a trend, and we see that in real life.
We are at 9 o'clock. Many thanks, Dr. Zemsky, for covering this very common and indeed complex topic. And just a reminder to everyone online to join us either virtual or in person next week for the Hansel lectureship.